Hello and welcome. My name is Chris Rowena, and I'm the lead communications analyst at HCAI Health Workforce. We're so glad you could join us today for the second in our series of Rural Health Transformation Program listening sessions. Today's session is focused on workforce development in rural health. Our aim is to hear directly from you, your needs, your challenges, and your ideas to ensure that California's planning for the RHTP reflects the realities of rural communities. Before we begin, go through a short housekeeping. Just a few notes to help you get the most out of today's session. Platform today is hosted in Zoom. Your controls are in the toolbar at the bottom of your screen. We'll be using the Q&A feature today for all of your comments and feedback. Please type your input at any time. Comments will be moderated before they appear publicly. And we are recording today's session. The recordings will be available on our website within 5 business days. A little bit about the session purpose and why we're here today. We're here to provide a high-level overview of the program's goal and structure, to share early survey findings to show how your feedback is informing our approach, and to listen to your thoughts, experiences, and ideas for topic-specific deep dives. Our commitment to you today is that we're here primarily to listen, not to present. Your feedback will influence how we design this initiative. This is the beginning of an ongoing conversation, and I'd just like to remind you again that we are using the Q&A feature to answer to have you answer our questions and to submit comments. This is a listening session. It is not a technical assistance webinar. So we're here to hear from you today. We'll have a series of questions that we want your feedback on, and we'll be discussing your input there. So with that, it's my pleasure to introduce Hova Khosrovian, Senior Policy Advisor for Workforce Development, who will be presenting today.
Chris, hi everyone. Great to see the huge turnout today. Really appreciate everyone taking the time out of their day to join us today and to learn more about the Rural Health Transformation Program and to give us your feedback. So I'm gonna go over a few slides here, really brief, to talk about the program itself, what we learned, and then really to open it up for comments through the Q&A session. I'll happy to address items and go deeper into some ideas, but definitely want to leave this opportunity for everyone to be able to provide their comments. Because such a large group, it is much more efficient for us to really have those responses through the messaging. We wish we could individually talk to everybody, but this is really like one of the ways, as well as reaching out to us through we'll show you later additional ways to reach out to us for more information and comments. So wanted to lay the land of what rural actually means in California. So fortunately, we received a notice of funding opportunity from CMS, Center for Medicare and Medicaid Services, about 2 weeks ago. I'm sure everyone kind of understands, this is an incredibly tight timeline for everything we're doing. Literally, the notice of funding opportunity came out on September 15th. And we have about a month. Actually, now we have less than a month to prepare everything. So it's a pretty intense timeline. So really appreciate everyone's patience while we're putting this together and your willingness to provide us information and details through different means rather than direct contact. So wanted to lay out like rural in California. So with that notice of funding opportunity, which we have a lot of acronyms we're going to use, called a NOFO. We were happy to see that CMS was using the federal, the HRSA, Health Resource Administration's Office of Rural Health Policy. It's called FORP, which is very beneficial to California because of the flexibility in the definition. So with that definition, we were able to identify about 82% of California is in rural census tracts. So it's also nice that they were able to use census tracts because that does give us quite a bit of detail on the populations living there, and it's much easier to track with all our other measures that we have for geography. What's great to see, and this is one of the things that we want to make sure is impactful for everyone, including in our proposal, is about 2.8 million Californians live in rural census tracts, which is about, I believe, more than 20 other states with their total population. So it's pretty significant in California. So you hear a lot about it. I think you've heard us mention it before. Not everyone across the country really understands how rural California is, and this is really a true measure of showing how significant that is. So So that's about 7% of Californians. That's one of the factors that goes into the funding opportunity as well in this program. Obviously, other states have much higher percentages, but again, we're really hoping to stress the number of people that we can really support through this funding to optimize the fund as much as possible. Uh, and we have about 57 of the 58 counties have rural populations. Sorry, San Francisco, but we did actually just a couple days ago realize there actually is a rural census tract in San Francisco, the Farallon Islands, which nobody lives on, mostly sea lions. So clearly it's not something we're counting. So that's why we always say 57 of the 58 counties have rural populations. All in all, as far as the infrastructure for the health systems in rural areas, I wanted to kind of highlight some areas. So there's about 279 rural health clinics. These are the certified rural health clinics that CMS certifies that are really there to support the populations that live in those areas and to provide basic services and be that safety net. There's additional about 296 federally qualified health center sites. These are just individual satellite clinics and locations. And then about 76 rural hospitals. Many of these are the critical access hospitals, small rural hospitals, some larger hospitals in there as well, but generally this is the breadth of the hospitals that are really supporting them. We do understand there are some situations where there's hospitals in more urban areas that support rural populations, and that's great too. We want to be able to support everyone as supporting rural populations. So that's one of the things that we're really focused on. And lastly, about 76% of rural census tracts are in a primary care health professional storage area. So that's one of those factors that we see consistently every year. And when we redo these designations, that there's always a shortage of primary care providers as well as behavioral health providers and dental providers too. It's not only one specific area, but one of the highlight just really on here on primary care, how significant that is, 76%. It's probably much larger on the behavioral health side. We know behavioral health is a shortage everywhere, and it's pretty significant. So you can go to the next slide, please. So I want to overview the program for the Rural Health Transformation Program. So it was established by HR 1. The funding is $50 billion across the country. It requires each state to identify with these 5 goals, 3 permissible uses. So here we're talking about 5 main goals. What's unique here again is, and we're doing listening sessions for each goal, is that a lot of these goals are interconnected. So you see here, today's focus is on workforce development. We're looking at how we can recruit and retain providers in those areas. We know consistently workforce is one of the biggest issues in rural communities, and how can we better support that? What was great to see in the notice of funding opportunity is that they highlighted some specific professions, one being community health workers and patient navigators and pharmacists as unique ways to address population needs for healthcare, help with chronic disease prevention, help with access. So you can see here how it connects with multiple goals here, the workforce itself. You can't make rural America healthy again if you don't have the workforce to support that. You can't be sustainable without workforce. You can't innovate, obviously, without having the workforce there to provide those services. And again, now we go back and we connect to tech innovation and how that workforce, how their work can be either like the pressure of so much work they have to do will be lifted with technology, and to optimize what they do and to be able to have them work at their full scope. That's really what's key. So today we're going to talk about workforce development. Really want to hear from everybody on what are some areas that we can focus on with this opportunity to support that and to sustain rural health with the workforce. So one of the big things we really want to stress with the Rural Health Transformation Program is that we're looking to improve healthcare access, quality, and outcomes. This is again using the term transformation. It's in the title, but it's also what really CMS has stressed with all their materials and webinars. It's what we understand and we want to do. Is this is not a one-time band-aid to support the infrastructure of the system of rural health. It's to ensure that that change happens and it's long term, so that we don't have to keep every year facing the situation of what's going to happen. Are these individuals in rural communities going to be able to go see their doctor, get access, continually see these chronic disease issues to grow? We want to be able to address that, and we want to be able to do it efficiently, and we want to be able to do it so it's sustainable. So one of the things that's been very clear is that this funding is not to replace or supplement existing Medicaid resources. It is not here for the cuts from HR 1. Unfortunately, HR 1 has many, I can't say many enough bad things connected to it. about all the cuts that everyone's facing. It's pretty damaging. This is not a solution, but it's one area where we can at least have that silver lining to focus on what we can do in rural communities to ensure the least impact and to make sure that the people that are living there can get access. That's really what's key. Next slide. So the funding is a little tricky with the Rural Health Transformation Program. It's 50 billion total. It's split in half. So 25 billion goes to each state, split evenly between each state that has an approved application. So assuming California gets their application approved, that would be 100 million a year for 5 years. So 500 million. There's a second pot, which is 25 billion. That is based on specific scoring factors, things like the rural population of the state, the hospitals that are in distress, the number of facilities, key factors as far as what the state is proposing in their application, whether they're programmatic changes, legislative changes, policy changes, key measures for improvement of outcomes for chronic disease, for workforce, for access. Those are all calculated to distribute the remaining 25 billion. So there's no guarantee on how much every state will get. One of the things we're doing here that CMS has requested in the application is every state apply as they're getting the maximum, which is 200 million a year, so a billion for the 5 years. And once we submit that, this is where, again, we really appreciate everyone's patience because at this point, once we submit on November 5th, the application that covers $200 million a year, then CMS will score the application and come back to the states, letting us know how much actual funding we got, and then revising our application to either decrease it from the original 200 million estimate to whatever it might be, and then decrease the proposals as well. Obviously, we can't do all the things we're planning if we have a lower amount. So there's still a lot to learn in this process. So really, I want to stress how much we appreciate everyone's kind of patience and understanding that there's still a lot of gray area with CMS and how much we initially will have to apply for, and then ultimately what we receive. The funding then will be determined, and then we can really have more detailed information to share with everybody once that's all figured out. But I really wanted to highlight here how the scoring works out. There's a few things, little images here you can see where many of them are data-driven. Initiative-based means what we propose, and then policy is legislative action or either existing or potential. Go ahead to the next slide. So there's 11 uses in the notice of funding opportunity. So this is where things kind of get a little complicated. There's five goals that we was highlighted earlier. Within those, there's 11 actual activities that each state will propose, and in going into detail how those will work. Each state has to pick at least 3. Now, understanding, and this is where we really want to be very, very frank with everybody. 200 million a year in California is not very much. It's impossible to overhaul all of rural health with 200 million, even if we get that full amount. One of the things we really want to do stress is that there's going to be some difficult decisions depending on what the final amount is. And even if we do get the full amount, it's really looking at what we can support to have the greatest impact. Knowing that there's certain things that are very at the top of mind, especially workforce, but we really want to be very targeted and be really sure of what we can do so that we can sustain this impact with the limited funding we have. So we wish there was a lot more. There's potential for more if we are successful with CMS. That's going into more of the weeds of the actual funding. One of the things I'll mention is CMS every year reviews your application scoring to see if you're improving. And depending on how you improve, you can continue your fund, potentially access more funding if there's remaining, or if you're not improving or you're doing things that they don't agree with, they can actually pull money back. So that's why it's very at this point, it's very tricky and very, very, very much a gray area of what is going to be consistently funded. But we're hoping to get clarity once we actually are awarded. So I want to highlight these 11 activities. You can see workforce there. One of the requirements in the notice of funding for the workforce, now it's not for every type of workforce activity, but generally if we're going to implement workforce activities that include any kind of direct funding to providers, whether that's like loan repayments or stipends, there is a requirement for a 5-year commitment in a rural community. So that does exist. And many of you, I'm sure, are probably familiar with our other HCAI workforce programs, like our loan payments and scholarships. We've naturally done that for many years. So it's very practical for us to know how to implement those. But wanted to make that clear that some of these funds will have these commitments. Um, another area to kind of look at how this all kind of coordinates is you can see workforce very directly impacts chronic disease prevention. There's also opportunities for provider payments if you want to try some new types of methods. Again, there's restrictions on that where it can't be payments for services that are already provided through public benefits or private insurance. But we really wanted to stress that we want to do as many of these as possible, knowing that with $200 million, it's going to be very difficult to do all 11. So we're going to have to really be very methodical about how we want to approach it. So you want to go to the next slide, please. So kind of the timeline for how this all worked out, I mentioned earlier. The application was released September 15th. We conducted our stakeholder survey. Hope everyone here was able to actually access and submit it. Some of you have actually submitted it separately through email, which is fine, which is great. We really want to get as much information from everyone as possible. So we really want to thank everyone that was able to submit information and provide their comments. It's really been helpful, and it's really strengthened what we thought we knew and what we actually learned too, because not everything was, you always have assumptions going into a lot of these different things. And then sometimes your eyes are open. They're like, oh, wow, we didn't realize that. So we're able to dive deeper into some of these areas that people pointed out to us. So now we're working on the actual application, which is, again, like I said, we have about less than a month to prepare it in order to have it be prepared for review internally and to make sure we get it submitted in time. Again, we're not waiting for the November 5th. We don't want to be one of those folks that applies the very last second and then hopes nothing goes wrong on the technical side. So we really want to focus on that area to make sure that we get the application in on time. And like I mentioned earlier, that there's a process once you submit it. So CMS will give you feedback. They will tell you how much you're actually going to have, and then you revise the proposal. All decisions for the awards have to be made by December 31st of this year. So that's good. It's a quick timeline for CMS. We understand that, so we're very hopeful that we hear earlier than that and not exactly on December 31st at 11:59 p.m. That's one of the things we're hoping that doesn't happen. And then this starts right away. So January 1st, if we're awarded, the program itself starts. If you read the HR1, the actual funds are appropriated starting in October. And real quick, I'm sure many have questions. We actually were in a conference yesterday with some CMS folks, and they highlighted the government shutdown has no impact on this program. This is mandatory funding, so this will continue as is. So just kind of address that real quick too, which is good news. So we can continue with this, and CMS is going to continue supporting it. So January 1st is when everything will begin. And then we have those 5 years to implement with 2 years to spend each time. And again, the process of rescoring and ensuring that we have our funding continuing year to year. Go to the next slide, please. So what did we hear? So this is amazing. We had over 350 individuals, organizations, facilities, community members, tribal partners respond to our survey, and it was just it goes to show that one, like I mentioned before, California is very rural, and how passionate everyone is about the rural community and ensuring everyone has access to services. One of the things I wanted to point out, we had 43% non-providers, and these are local county organizations, departments, individuals affiliated with local county governments, academic centers, philanthropic organizations, and health plans. 57% were healthcare providers, and this covers the full breadth of healthcare providers, so facilities and actual clinicians. So it was amazing to see how many organizations we were able to hear from. Really, we're very excited about that, and very excited to see so much in-depth comments and thought put into some of the comments that were received through the kind of the open text field as well. So this was just amazing to see, and we're really happy that we were able to hear from everybody. Go to the next slide. So one of the things we really want to focus here on this workforce development area, the goal here, again, like I mentioned, is to really build and sustain that workforce. It isn't kind of like a, one time, here we go, here's a bunch of providers that we're going to support. That's it. Good luck. Hopefully this will work out in 10 years from now. We really want to ensure that this is sustainable. You have workforce there for many years to support you, and then that will really connect to all those other goals that we have. Like the making everyone like the chronic disease prevention, like the innovative care, and trying to do some of these like potential opportunities to really support everyone. And workforce is the key. Workforce is the building block for all that. You can't do any of it without having a workforce. So there's specific areas that CMS has called out for workforce that we want to be aware of, because we know in this application process, the more we align with what CMS has highlighted, the better our chances are of getting the full funding opportunity. They highlighted recruitment and retention, which is obviously one of the big areas. Generally, when you hear recruitment and retention, you think loan payments, scholarships, stipends, but also includes pathways. So one of the things we know is very clear. Just offering loan repayment is not enough to have provider to fill that need. There's also in making sure individuals from those communities have the opportunities to move within their professions, whether starting off in high school, learning about health careers, learning about it from their local community college, learning about it from different training programs, or just being already working in that setting and then seeing the opportunity for them to upskill and move up in their career path. We know those are the individuals that will stay in those rural communities, and that's really what's key is having that process there and that pathway, and that's what also is sustainable. Once you start seeing those results, it's very clear to everyone within the community, within the state. These are programs you want to support because look at the impact they're having. They also mentioned training programs. And again, this goes back to residencies, fellowships, allied health education. We all know there's many programs out there, some federal, that provide rural residency tracks. We know that's effective. We know in residency programs themselves, generally residents, when they graduate, about 60% stay in the area that they trained in. So it's really key to have, it's a key way to get physicians into your community by having them trained there. But again, that's not the only answer. There's more than just physicians that need the support. So we want to look at how we can grow other professions within that area through training. CMS also called out scope of practice. Now, we know this is a very sensitive issue. It's not something that you can just say, "Oh, we're going to, expand everyone's scope of practice." That's not what we can easily do, but it is something that is worth thinking about. What can California do? What would this program do to enhance those that are already working there, to ensure they're working at their full scope, as well as enabling them to work at a more advanced scope that aligns with the needs of that community, and that's what CMS is looking for. And then lastly, one of the things that we really were excited to see was these community-based roles. CMS, within the notice of funding, called out a number of times community health workers and navigators as a key way of ensuring individuals get access. So it's great. We have a number of different opportunities that we're working on the community health worker, promoters, and representative side. Some of you might be familiar with that. It was really exciting to see this because we also think that their community health workers, navigators, and peers are a really key resource in these communities to enable individuals to get access, to not have to worry about leaving their home and traveling for an hour to get to the nearest clinic or hospital, addressing their need at home and ensuring they're comfortable and they get the support they need. So it's really exciting that we got to see this, and we're really looking forward to identifying some ways where we can really enhance the roles of these providers to support the not just workforce, but you can see it throughout the other 4 goals where these individuals are really key to addressing a lot of those factors and the other goals as well. One of the things we know from just working in rural communities and hearing from everybody is there's always shortages of providers, whether that's physicians, nurse practitioners, allied professionals, behavioral health professionals, dental professionals. Across the board, there's just a need for everybody, maternal health providers, and there's very high vacancy rates. We know local training, career development is important for retention and building that community trust and feel. And then we also know that a diverse, well-supported workforce is really what's key. Each community has different needs. We want to make sure each community's needs are addressed through their workforce, and that's what's so relevant for this program. Next slide. So here's a few things we actually heard from folks. I'm going to kind of speed up a little here so we can get to some of the comments from everybody and any questions that might need answering. But you can see at the very top, everyone kind of identified through the survey data. Loan payment is really key. Retention bonuses, rural residency, and going on to housing. Again, that's a key thing we keep hearing is being able to include when providers come to those areas, can they find housing? Can they have some kind of support system? Then career advancement and then community integration are the keys. Go to the next slide, please. So this is kind of some more of the things we heard through the survey. So again, we looked at recruitment retention. That really came out loud and clear. Training programs was very aligned as well from many of the comments. There's also the local workforce pipelines, non-physician workforce. We know it clearly, like we spoke about community health workers and how key they are to the process, as well as care coordinators, peers. They're all very important to the full scope, whether it's primary care, behavioral health. They're really key for that chronic disease prevention and getting to those preventive services. And we look at licensure again. We know it's a little tricky of an area, but we really want to be able to address that and show that these are areas that potentially are opportunities for us, as well as working on that burnout and retention support. So one of the things and everyone saw the goals, innovative care and tech innovation are key, and we're really hoping that maybe potentially there's opportunity there to reduce that burden on the paperwork and to improve that work-life balance, because we know improving burnout will directly improve the retention of your workforce and bring more people in. Honestly, if you have a good reputation of like, hey, this organization is very streamlined, you get to do the work you want and you get to help people, which is what they're there for, that gets around and people really quickly start wanting to work within those facilities and organizations and work in those rural communities. So it's really key that all of these work together. Go ahead to the next slide. So with that, I wanted to pose a few questions here and really ensure that everyone here in this session is able to provide some comments on it. We really want to learn from everybody, hear what you think and have to say. One of the things I wanted to ask everybody in the audience is really what helps bring health workers to your rural communities and what makes them want to stay? What are some potential areas that you've seen work, and what are some areas that you're like, even if it didn't work, we really want to know that, because we really want to go down. We don't want to go down the wrong path of proposing an idea and presenting it, and everyone's saying, "Oh, that is a terrible idea. We tried that and it did not work." So really, whether good or bad, please let us know what are some areas that you think are really the most beneficial, knowing that we have a limited amount of resources and funding. So what can we make the best use out of that? So really, we want to address that. We want to address, besides physicians, again, what are some of those other roles that really can help fill that gap, make sure everyone has access. We also want to look at the types of support that are valuable to really have that grow your own model and to really support the individuals in those communities, whether they're working at the facility already or even earlier in education, in high school and earlier, to get that impact in community. Feel so they can get exposed to health professions and then work their way up and remain in those rural communities. And then lastly, what resources, whether it's training or day-to-day support, do you think providers need to reduce that burnout and make the biggest difference for growing your staff, ensuring their well-being and ability to serve the community? So with that, I really want to have folks put in some comments. I'm happy to dive deep into some of them if we need to. I can even ask, if I see anything there, I can ask a follow-up question. But really wanted to open up comments for everybody. I know there's been a few so far within there, so happy to Chris, let me know if there's anything specific that you saw that you might want me to address or answer.
Yeah, thank you, Hovik. As we move into the listening portion of this session, this really is the heart of today's conversation. Again, to participate, as many of you have already been doing, click the Q&A button in the toolbar and type your input into for these questions or your general comments as well. And again, this is a listening session. Our goal is to gather your input. And remember too, some of the details are still in development. We don't have all of the information yet, and so we'll do our best to get through everything as we can. So Hovik, the first comment that we have is recruitment and retention are challenging in rural areas for primary care providers. Do you want to speak to that?
Yeah, and we've seen that too through various kind of studies and surveys. I know there's been a couple of national surveys in years past that track the kind of retention. We know certain aspects of the programs work. So one of the things we know is within loan payment, when you offer like loan payments and stipends, generally you have about 60% of those individuals remain after 5 years. Every year past that, it kind of does decrease. But one of the things we look at is what are some of the underlying issues? We know we've heard from many communities support system is needed when you bring in a provider, whether that's their partner or spouse, having an ability to work in that community, knowing what's available to them and their family, knowing what kind of benefits are there for them. So one of the things we've always kind of hear is that community engagement really helps tie an individual. So looking for ways we understand like that's always the retention is troubling and the recruitment is difficult. But one is recruitment having the benefit of like financial benefits like loan payments or stipends, retention bonuses, signing bonuses is an opportunity here that we could potentially propose. But then once they're there, it's really key is how do you keep them there and how do you like again go back to the retain, and that's where we've seen like from different comments from different organizations, it's that building that community feel, building that connection to the community for those individuals is really most effective, and we even heard that recently from some of the much more rural states. Is how do we is some ideas that we've heard them speak about is making that connection and ensuring that the community like knows them, can rely on them, can relate to them, and is they're part of that community. That's really what really focuses on it. So would love to hear like potentially what ways that can happen. I've seen certain like facilities do certain things with providers to like really make them incorporated into the community. But really, one of the things we want to look at is as we develop proposals and we integrate some of these workforce options in there, is what actually I forgot to mention this. We're not looking at like cookie cutter funding opportunities. Each area is unique. Each community is unique. Frontier is very unique from rural, from rural that's like 45 minutes away from urban center, from rural that's down south in the Imperial County, to communities that are up in Siskiyou and Modoc. Very different needs. So we don't want to make something that's like here you got to do this and only this. It's here's what our goal is. Here's some potential uses. Tell us what you think is best and implement it that way. Because we, at the end of the day, we want the goals, we want the outcomes to show that positive outcome. So again, it's I don't think we'll have all the answers. I don't think this program's gonna have all the answers. What it has is the opportunity for us to try and to stabilize the workforce and to grow it in new ways that potentially we can learn from. And then we can either, whether it's like a pilot or whether it's just, full scale implementation, we want to learn so that we can have this addressed. So again, wanted to stress, we're not going to work on having these cookie cutter, like, do these 5 exact things and nothing else. It's more about, here's where we want to get to, here's some funding. Tell us what you can do to make that happen. So again, yeah, it's a challenging area, but we really want to make sure that so they have opportunities for folks in these rural communities to use what they know, rather than a top-down approach. It's more from the ground up approach.
All right, thank you, Hovik, for that. Next comment we have is Medi-Cal peer support specialists, certified wellness coaches, registered alcohol drug technicians, wants to build social network partnerships with substance use counselors, LCSW, MFT, LCCP, LEP, be available for training in develop RHC, FQHC, and rural hospitals. That was a lot of acronyms there.
And yeah, thanks, Sylvia. That's a great comment, and that's one of the things we're looking for when with all these comments is what are potentially opportunities that we either have missed, we know exist, but just haven't known the scale of it. One thing is that kind of cross training and that team-based care. So you've probably some of you probably heard us many times talk about team-based care and care coordination. And that's within the actual notice of funding too. They talk about that as well. So that's one thing we wanted to also address is that team-based care and is that a potential opportunity for in workforce for folks who want to feel supported because now they have a whole team around them, whether it's physicians feeling like, okay, they don't have to do every single detail of a patient's care because they can go focus on the pure medical need, and then have all the other providers, whether it's nurses, whether it's community health workers, whether it's peers, being there for them to address some of the more less urgent, less severe needs of the population, and expand that and have communication. That's one of the other things we always kind of hear is that communication, that team-based care is once a physician helps someone, many times we hear in behavioral health, if a primary care physician helps someone in behavioral health, and they refer them, sometimes it's the last they ever hear of what happened to that person. Like how do things go? And having that team-based care really connects everyone together and ensures that there's continual support for that individual and that all aspects of health, whether it's primary care, behavioral health, and oral health, all working together to create that, again, we'll go back to that kind of disease prevention and chronic care management. It all kind of works together. So that's one of the things we're hoping to hear is what are some potential ways to do that training, to do those partnerships, and have it open so communities can actually propose that within like some of the workforce components.
All right, thank you, Hovik. Next one is the reduction of the administration burden will support the retention of staff, including the use of innovative technology for documentation, scheduling, interoperability, care coordination, and to improve continuity of care, which ultimately can achieve staff satisfaction.
Yeah, that's great. I hope whoever put that in there attends the innovative care session and said some more feedback, because one of the things is we have innovative care and then we have technology innovation as part two of the goals. And that is one of the factors is what can we do, whether it's telehealth, whether it's different systems for whether it's referrals, whether it's follow-up, whatever it may be. There's a lot more in the medical world of technical systems that I probably can't even figure out what they actually mean. So it's not my area of focus, but it's definitely is areas that we want to hear about. What technology improvements could actually improve workforce? Because again, going back to how everything's tied. So please, yeah, share what you know and what you have. And we'll have an email address at the end later too. We want to hear about these proposals of like, what can we do on the innovative side to really lift that burden on all providers, not just, at the highest level with physicians, but, all supporting providers, all advanced practice providers. We really want to know what that is so we can see how we can support that through this program. So it's really key. And again, always kind of, keep reiterating it. It's all connected. The workforce connects to the innovative care, connects to the chronic disease prevention, connects to that sustainable access. It all works together. So being able to actually show in our proposal that here's a workforce component we want to focus on. By the way, it also impacts technology. It also impacts sustainable care. Is a great way to have our application not just score higher and potentially increase our funding amounts, but also make it much quicker for us to implement because we know what's needed and we know what we can do right away. Calling it shovel-ready options, proposals, but things along those lines are really key for us to hear about. So yeah, I really appreciate that comment.
All right. Mary Flett says, primary issue in my county is funding needed to pay for caregivers and respite.
So one of this is where there's still some gray area with CMS. So one of the things they allow us to do is to provide payments to providers. Again, like I mentioned, outside of anything that's actually billable. And there's a cap. Believe it's 15% of the budget. So it's limited, but there is opportunities here for potentially trying out kind of new services for providers of all levels, but offering up potential a service here that can enhance that workforce and give them the opportunity to kind of do what they love and to also support potential opportunities for individuals that might not necessarily have always gotten that access. One clear thing we've seen mentioned in the notice of funding is maternal health. So if there's opportunities to have additional kind of providers in different roles supporting maternal health, there's potential there as well. So those are the kind of things we want to understand and know more about. So if there's again, and going back to caregivers and respite, we understand that too. We know skilled nursing is very key. Skilled nursing facilities are very key in these rural communities. A lot of the rural community, and we've looked at some of the data, is a much older population. Some hospitals have skilled nursing facilities connected to it, so we want to also understand what we can do there for potential support of that workforce. Again, it's all connected, so we know that some rural communities might not necessarily be able to support a provider full time, but if there's opportunities to work as a community, as a region, collaboratively, to say we all need this provider, whether they're at one facility or shared between multiple organizations facilities, those are the types of things we want to hear. Is it feasible to even try to approach it that way and say, yeah, we understand we're never going to get a psychiatrist in this community because we don't have enough patients, but we have 3 or 4 facilities that could really use that based on the populations there, and could we potentially share that? So opportunities, whether that's that's just a wild example I pulled out, but if there's opportunities for nurses, for community health workers, for advanced practitioners to be able to work between different organizations in that kind of regional collaboration, that's really what's key and what also CMS is looking for.
All right, thank you, Hovik. Katie Layton says we are seeing unprecedented and worsening trends in the pipeline of physicians choosing to go into pediatric specialty care. A number of pediatric specialty fellowships have fill rates near or below 50%. Do you see a role for RHTP funding to help increase access for children and youth who need to see a specialist? If so, what do you think are the most viable proposals to include? We are strong proponents of loan forgiveness programs similar to Cal Healthcare's a program that was created with Prop $56.
Yeah, so we know loan payment programs work. I would love to say that that answers all the questions about recruitment, provider recruitment retention. It doesn't always. So we want to make sure we coordinate loan payment. Like loan payment's not the only option. It's coordinated with other efforts to ensure yeah the services are there, but potentially what other services can we provide through different innovative means? So specialty is one of those questions that keeps coming up. Specialists are it's very challenging to have a specialist, specifically like in some very rural communities. So how do we address that? Whether is that through telehealth? Is that through kind of different models of care that have a central kind of entity who then kind of is able to support that smaller organizations with the specialty services. So those are the things we really want to like think through. But it is, yeah, specialty, maternal and behavioral health are like the key areas that we really are focusing on what's needed. So we can figure out, yeah, some situations it's just not feasible to have that service provided in the community because of the volume, and the providers aren't going to be necessarily be able to be there. But that doesn't mean we want to say, you can't have access because you live there. We want to figure out how we can build that in using either technology or different kinds of types of services or even pilots that have already been implemented, learning from them to see what we could put in there that gives that individual an access to a specialist, make sure they have full access, meaning, any day they need them, and then the ability to actually see them in person when needed. So those are some of the challenges. Again, it's hard to say we can address all of this within the next less than 30 days. But what we really want to do is make sure that we identify what we need and build flexibility. And so the next 5 years, we could really narrow down the funding and how it could be used. So that's really what's key here. So again, yeah, I understand loan forgiveness is really helpful, but what else can we do to get those kind of specialty providers within those communities, or at least access for those communities to them?
All right. Meredith says older adults and people with disabilities need access to long-term care options in rural areas. Workforce needs to include RNs and CNAs. We ask that they be a focus on LTC to maintain and improve access in the rural areas. In addition, navigators are needed to help people access CalAIM services such as the assisted living facility options in rural areas.
Thanks. Yeah, thanks, Meredith. That's really important. So that is one of the things that we're trying to like also identify is as we work through with CMS and what's allowable, what's not, and the whole structure itself of the hospitals, the SNFs, the support facilities all around them. So yeah, really appreciate that comment, and it is something that we're trying to like think through and see. Like I mentioned before, it's very difficult to get some of those professions in there. So what are some like key or innovative ways to bring them in and to ensure that they're there, but also have that kind of support? So it is something that we're looking at and trying to identify. And so I really appreciate the call out because it is important, especially with the population, the age of the population in those rural communities. We don't want we don't want to have them feel forgotten. We want to make sure their needs are addressed, and they have very unique needs that doesn't necessarily fit with individuals that are younger or different areas. So it's something that we really we were focused on. So, and that's what we're trying to address. So any opportunity, if you have to like send us, additional comments about potential ways to address it, please do. We really would love to hear that.
All right, thank you for that. Let's see. The next one is from Andrea Mitchell. While many organizations are committed to developing rural residency programs, one of the greatest challenges is attracting program directors willing to lead these programs in rural locations. Providing targeted incentives could make a critical difference. Support such as housing assistance or enhanced compensation packages would help recruit and retain high-quality program directors, ensuring these rural residency programs can thrive and meet the pressing healthcare needs of underserved communities.
Thanks, Andrea. Yeah, it is. So I'm sure everyone's familiar. We've done many residency program funding. So Song Brown's our biggest one. We do some psychiatry ones. Yeah, it is an issue. One of the things that we're hoping, and this kind of goes back to the gray area at CMS, is what the flexibility is, how to use the funds. Again, if we do go down the path of like rural residency or rural residency tracks, it's giving enough flexibility to the programs that want to use it to address things like the kind of like that. I don't know if you call it wraparound support or like services for those individuals, especially like bringing in a program director. We want to give the flexibility because we want at the end of the day, like I said, is the outcome successful. And if it's a different way of doing it that we've done it in the past, that's fantastic because now we've learned something that we can actually implement even internally within the state, not just federal at the federal level. So we want to ensure as we develop these programs, whether it is residency, whether it's a different kind of training program, that it isn't fixed as you have to do it this way. It's what do you need to do in order to train those individuals and get them the support, whether again, get that's, how that's used. We're hoping CMS gives us a lot of flexibility on that. But yeah, it is something that we've seen as well within our own program. So we're hoping that this is a way to have the flexibility to address it.
All right, thank you. Let's see. Laura Fierce asks or says, identifying and aligning health workers with their own personal wants and needs. Um, oh, it just disappeared on me. Where did it go? Hold on one second. It got moved.
You might have got answered offline.
Okay. Um,
Yeah.
all right.
Um,
Yeah, next one. Let's see. We've got Carol Malo, funding for continuous training on SME and technical skills, team building activities, and travel support.
Great. I really appreciate that. Just quick, I know we use a lot of acronyms, so I'm trying to remember what SME is. So do you mind just
Subject matter
commenting
expert.
on what SME is? Just
Subject
as a
matter
subject matter
expert.
expertise, is that what it is? I thought maybe
Yeah.
something else. Okay. Yeah, no, appreciate the comment. Yeah, that's one of the other things too is there's some areas in the NOFO that talk about training. Some interesting areas where they talk about nutrition as well, which is very odd given that some nutritional funds were cut. But there are talks about like training for providers to be more aware of nutritional support for individuals so they can pass that down to the patients. That was actually one idea that was in the notice of funding. So interested if anyone has any comments on that. It was actually about requiring continuing education courses in nutrition for physicians and other providers who could then use that for their population. So it was one thing that was called out very specific. Usually when it's called out in NOFO, it's probably good to include it. So just curious if anyone has any comments on that, if that's something that's even feasible. But happy to take that comments like that through our email as well. But it's just kind of a question I had top of mind. But definitely, yeah, we want to have continuous training because one of the things that does call out in the notice of funding is kind of like that upskilling. So we want to know how we can upskill folks so they can provide additional services that necessarily might not be available to others but are still within their scope or their abilities. That's really what's key.
All right. And I did find Laura's comment. It just got moved around. Identifying and aligning health workers in their own personal wants and needs, such as outdoor activities, then need professional growth and support opportunities. That was from Laura Fierce.
Thank you. Yeah.
All right. Let's see. We've got about 10 minutes left. We're going to keep pressing on. Really appreciate everybody's interaction with us today. There's great feedback and comments. Here's one that we've got. Let me make sure that. Okay, here we go.
And
Washington State leads with obstetric outcomes in part because of the integration of community midwives, licensed midwives, and certified midwives in their system. California might follow suit, and I understand some aspects might be legislative, such as prescriptive authority for LMs, but increasing education opportunities, which is currently underway. Building on that could benefit rural communities.
yeah, I don't know if that's someone from Washington that added that, but I appreciate that. Actually, I was just at an event in Washington, was there talking about that, and it's amazing what they do. So we definitely are open communicating with other states. One of the things I've always kind of said, and I think many of us do, is you can learn a lot from other states, particularly the states that are primarily rural. They're very innovative because out of survival, they have to be. So they move very quickly. They're very innovative, and they do things that you just are like, wow, I can't believe that. Like, how'd you do that so quickly? And then you see these amazing outcomes. So we are working with other states to kind of see what they're doing. Hopefully, borrowing some ideas if they have like something that we know work from them. But yeah, I know Washington, like from what I've seen from their maternal health side, it's pretty impressive what they do, and it requires some work for California to kind of get to that point. But again, those are the kind of things we want to like look at and potentially talk about and see if it's even feasible here. I just want to add, I'm seeing a lot of the like amazing comments in here. I just want to really appreciate all the thought that's everyone's putting into these comments. This is really what we're looking for is like besides the survey information and all the different like emails and letters everyone sent, having this opportunity to hear from everyone and just know we are logging all these comments, so it's not going to just disappear once this session is over. So hoping that if individuals, I think we should have most of your contact info. So if something in there that we're like, oh, that's really interesting, like we would like to pursue, talk to you about that a little bit more. If you're open to like having us reach out, that'd be great. Knowing we have very limited time, so might not be able to reach out to everybody. But really, really, yeah, I want to say thank you for all these amazing comments. It's really helpful to see all this and to like kind of know if we're on the right track or there's things that we've missed that we really need to identify and address as well.
Absolutely. This is a great engagement. We really appreciate it. Colleen Rodriguez says, local PH department here, public health, our biggest struggle of recruiting and hiring CHWs, providers, etc., is housing. We've created our own pipeline, slow going, for CHWs that live locally, but truly struggle for clinical staff that are not connected or rooted in our rural community.
Yeah, and we know from our community health worker promoters and representative work that is a challenge, bringing folks in. And it's, again, community health workers, it's amazing what they do. And I'll just be very honest, they're not compensated enough for what they do. So it's something that really we're hoping that this program can help support. Now I don't know like how that works out with payments. Payments is a whole different issue, and going into like the reimbursement rates, that's very outside of anything that we're doing here. But it's something that we want to really be able to address. Like, what are some innovative ways, yeah, creative ways to get people to come to an area and work, but also to be able to like live there. And again, we're not quite sure how housing kind of can go into that with what CMS will allow, but it's definitely something that we're following up with CMS to see like what actually is allowable in those areas.
All right, thank you. Lynn Jacobs says, I have worked in a rural clinic where providers came and went depending on their loan repayment commitment. If the family isn't happy in the area, they will leave. It is primarily family and a strong desire to be close to amenities in the area, skiing, hiking, etc.
Yeah, that's one of the challenges. It's one of the areas that I think we're trying to work through, like how, again, kind of goes to that community engagement and having them feel like they're part of the community. Um, but appreciate the comments. I think it's a struggle. I say the least for rural communities. But we're hoping again. This also has kind of shows how it all connects. We're hoping as we help transform the rural system, and if we're able to make some significant impacts, whether that's through tech, through chronic disease prevention, what it does is it increases the awareness of what's needed, and it shows to providers, hey, you can come work here and actually do what you want to do to quickly impact individuals, work with them directly, work on areas that you think like that you're familiar with, comfortable with, and are impactful. Because rural community, because they are smaller, you can actually have a pretty significant impact as a provider there. So that's one key, I think, aspect that we really want to learn about, and how to like motivate individuals to work in those areas because of what they do and what they love to do, and how it can have such an impact in these rural communities. And I know we're running low on time, Chris, so I don't know if
Yeah,
there's any
we've got
other.
time for a couple more questions here,
Yeah.
or comments, I should say. Um, All right. The next one is what brings health workers to rural communities and makes them stay? Organizational culture, strong support of medical providers, team-based care and integration, as well as having competitive wages. What makes them stay is reduction in documentation burden, a balance in their implement to reduce burnout, from having full panel patients to complex chronic health conditions. There has to be providers to be able to balance empanelments, excuse me. The shortage makes it impossible to accomplish.
Yep. No, thanks for those comments. It's something that we're still trying to work and understand. So completely, yeah, agree with that. So I know we have about 5 minutes left, Chris. That I know there's a lot of comments. I don't know if there's actual like I know there's also opportunity potentially to ask any questions if anyone has specific questions. I don't know if we want to keep going through the kind of like comments or open it up for like maybe one or two specific questions that anyone has that I can respond to because I do want to give some folks the opportunity like at least a few minutes. I'll try to go through as quickly as I can through answering some questions, but feel free to add any again. This isn't a technical assistance webinar, so I can't answer direct content details about any kind of specific proposals or the funding, but anything like more general about workforce in general, the topic, or this rural health transformation, I'm happy to kind of answer right now if anyone has a question. Additional comments, yeah. If you want to go to the next slide, like next couple of slides to give everyone the contact info.
Yeah, we can do that now if you want, and come back to any questions as our team identifies them. Yeah. So once again, just want to thank everybody for your participation today. We will get to hopefully one or two more comments and questions here. But we are capturing all of your questions today, even those that weren't answered. We have a record of everything that you have given us. It is invaluable to us, and we really do appreciate it. We do ask that if you think of something later, please email us at calsor@hci.ca.gov. And you can see that on the screen there because your feedback is an essential part of shaping California's plan for the Rural Health Transformation Program. And so, again, you can also follow us on social media. I should mention, yeah, go ahead, check out our website and follow us on social media. And then we're doing things a little out of order here, so I'm a little turned around. On that previous slide, we do encourage you to sign up for our monthly newsletter for Health Workforce. If you are not already, you can go to the subscribe link on our website or to this one, and then you click on anything that's under the Health Workforce section in that, and you will be added to our monthly mailing list. And great information that we keep you up to date on there. Do want to mention that any comments that you have, please have those to us by Friday if you think of anything. That way we have time to incorporate them in the plan. So let's see here. Scrolling through, looking to see if there's any other questions. We've got about 3 minutes left today.
I just want really whoever is sending in all this information about the Grow Your Own, really appreciate that. It's really helpful for us. It says anonymous, but I just wanted to say thanks after these last couple of comments.
Absolutely. And looks like I scroll back up to where we were.
There is one comment, just wanted to quickly address. So Mary said about the innovation not being really attainable. So it is, yeah, that is one of the challenges is like this short time frame. Like, one example is in NOFO, they talk about, and this might be outside of some people's like kind of knowledge base, but like value-based care and alternative payment methods. In those instances, there are areas where it's like just impossible to implement something like that in 5 years in such a large state. But there are opportunities I think, for us, at least as how we're seeing it, as if there's potential like pilots for some innovative ideas to pilot those in areas that like we can determine like as far as what has the greatest need. But we don't want to we just want to address that. Yet true innovation across the entire state probably is impossible in 5 years. But if we're able to do some innovation in like certain regions or areas, I think that's one potential area where we can kind of show that.
All right. I did find a question that we wanted to flag here for you, Hovik. Is there an opportunity to enhance the role of the peer, CHW, and navigator with digital training and tools to teach community members to embrace the use of technology to use RPM to help better manage the health and chronic conditions?
So there's nothing is off the table. I mean, we're building the proposal now. So we do. So there is. We just had the tech innovation, but yeah, feel free to send us some comments on some of that area with like the cross between those community health workers, peers roles and technology. Be really interested to know like how what they do now potentially if there's anything successful and what they could potentially do in the future. Because yeah, it is an area where we're really thinking like how we can get these roles to use that technology because that's one way of expanding access. There's examples in the NOFO about folks, community health workers going into someone's home and doing their vitals checks instead of having them, leave their house and drive for an hour. So we want to learn about things like that. So please, yes, submit to that email as much information as you can think of on those connections between workforce and technology.
All right. Well, we are out of time for today. Thank you, Hovik, and thank you everyone for your thoughtful participation with us. Again, we really do appreciate your interaction and all of your wonderful ideas. This feedback is essential for shaping California's plan for the Rural Health Transformation Program. And again, please stay in touch with us both on our website, our socials, sign up for that monthly newsletter. This does conclude session 2 on the workforce innovation for the RHTP listening sessions. Please join us tomorrow at 10 o'clock for session 3, and we have session 4 following that at 2 p.m. Tomorrow as well. And then we have one more session at 10 a.m. on Friday. And we really appreciate you joining us. We look forward to continuing the conversation in the sessions ahead, and we hope you have a wonderful day. Thank you.